Ethics, the case study of Finn. Good evening and thank you for joining me. Today, I'll explore a challenging ethical dilemma in psychology through the case study of Fen, a 19-year-old gender-fluid individual. Fen, under my care for anxiety and depression, has recently disclosed an eating disorder. This revelation poses a critical ethical decision for me: continue our therapeutic alliance or refer Fen to an eating disorder specialist, risking our established trust. Utilizing Kuchar and Keith Spiegel's ethical decision-making model, I'll analyze this situation guided by the APS Code of Ethics to uphold professional standards. The core ethical dilemma here lies in balancing professional competence and client autonomy in the context of informed consent. According to the APS Code, psychologists are required to work within the areas of expertise determined by their education, training, and experience. My lack of experience in treating eating disorders poses challenges in addressing Fen's specific needs. At the same time, the code underscores the significance of obtaining and respecting informed consent from clients. Fen's preference to continue therapy with me, despite being informed of my limitations in this area, creates an ethical conflict. This situation highlights the need to reconcile the client's autonomy with the ethical obligation to practice within one's professional boundaries. It's crucial to navigate a path that adheres to ethical standards and respects the client's wishes. Confronting the ethical challenges presented by the APS Code of Ethics demands a balance between professional guidelines and personal convictions. Standard A36 stresses that psychologists should seek a client consent as far as practically possible, whereas B12 states psychologists should only provide psychological services within the bounds of their professional competence, including but not limited to their education, profession, and their emotional capacity to provide a service. This dichotomy is evident in Fen's case, as her disordered eating falls outside my expertise, yet she is reluctant to be referred. Before proceeding, it's crucial to reconcile my personal morals with the professional ethical standards that govern my practice as a psychologist. As a woman from a collectivist culture, my cultural background ingrains a sense of communal care and sacrifice and makes it hard to assert my own needs, a phenomenon documented in a review by Kim. Encountering Fen's distress and her belief in my unique ability to assist her would tempt me to extend beyond my professional boundaries to address her eating disorder. Moreover, my personal history with eating disorders within my social circle offers a point of perspective on their severity, fueling my drive to seek adequate support for Fen. This emotional connection could potentially cloud my judgment, leading me to prioritize her immediate welfare over the ethical mandate to secure her consent for a referral. Additionally, balancing these intense feelings with ethical protocols might compel me to consider terminating our sessions, as it would greatly affect my own mental health, and burnout in clinicians tend to be higher in women. The next phase involves a detailed evaluation of the ethical rights and vulnerabilities of all involved parties, namely myself as Fen's psychologist and Fen as my client. For Fen, the key rights include the right to have her wishes heard and respected by her support system, the right to self-determination, the right to autonomy over her own body, the right to receive competent care. These rights align with the APS Code of Ethics, particularly in terms of respect and informed consent, emphasizing that psychologists should, as far as practical, seek the client's consent and respect their autonomy in treatment decisions. Fen's vulnerabilities are multifaceted and include susceptibility to societal pressures and patriarchal views of women's bodies, the risk of maladaptive coping mechanisms, such as her eating disorder, potential malnutrition due to inadequate food intake, and increased risk of emotional outbursts triggered by factors exacerbating her eating disorder. As Fen's psychologist, my rights encompass upholding ethical principles, including respecting the client's values and rights, the discretion to select client and terminate services if necessary, the responsibility to act in the best interest of my client within my professional limitations. However, I also face vulnerabilities, such as the psychological impact of working with Fen potentially affecting my self-esteem and perception of my capabilities as a psychologist, the possibility that these challenges may lead to the termination of our professional relationship despite forging a therapeutic bond. These considerations relate to the APS standards for termination of psychological services, which mandate that psychologists should consider the inherent psychological processes and the client's well-being before ending a professional relationship. Two possible decisions are the following. First is a referral. I could refer Fen to a specialist in eating disorders, explaining the need for appropriate professional care, which lies outside my expertise. Despite our strong therapeutic bond, this move prioritizes professional competence and Fen's safety. The referral would be sensitively managed to affirm that her well-being is paramount. Alternatively, I could continue treating Fen while actively seeking additional training and supervision in eating disorders. This respects our established therapeutic relationship and Fen's preference for continuity. This route requires my commitment to rapidly acquire relevant skills and collaborate with other professionals to ensure Fen's safety. In both scenarios, Fen's participation in decision-making is vital, with a focus on her safety and mental health. My dedication to ethical practice and professional growth will be clear in either choice. Analyzing the positive and negative consequences of each decision can help determine the most ethical and effective course of action. Here is an examination for both decisions. The positive consequences of referring Fen to a specialist include beneficence and non-maleficence. By referring Fen to a specialist, I am adhering to the principle of beneficence, which requires taking actions that benefit the client, and non-maleficence, which also ensures Fen's safety, and making decisions that do not harm Fen. Professionalism. The referral upholds the principle of professionalism, which includes recognizing the limits of one's competency and seeking consultation when necessary, as is the case with Fen's eating disorder. A higher chance of obtaining informed consent. This decision prioritizes educating Fen about the consequences of receiving inadequate care for her eating disorder. By acknowledging her decision to keep me as her clinician may be motivated by acknowledging that her decision to keep me as her clinician might be motivated by a heightened affect, which may not be a true reflection of a decision she would make for herself after being rational and adequately informed. Utilizing the mental health care network. By utilizing this network, it allows me to seek counsel of another professional regarding Fen to make informed decisions about her treatment from my end to further assist with her eating disorder. Reduced burden on psychologists. By delegating the care of Fen to another specialist, it reduces the burden of being Fen's sole support and allows me to recuperate and deliver services that I am emotionally capable of giving. Negative consequences. Risking the therapeutic alliance. The potential rupture in the therapeutic relationship may violate the ethical principle regarding the maintenance of trust between the client and the psychologist. Continuity of care. A referral could disrupt the continuity of care, which the APS Code of Ethics suggests should be a consideration in decision-making. Client autonomy. In the case I am unable to persuade Fen to accept the help of another specialist, by referring Fen against her wishes, it may be perceived as not respecting Fen's autonomy. On the other hand, we should analyze the consequences of continuing treatment with supervision. The positive consequences include respect for the dignity of persons and peoples. By continuing treatment, I respect Fen's dignity by respecting her preferences for clinicians and who will treat her. Professional development. My commitment to expanding my competence through supervision is in line with the principle of professional development and lifelong learning. Client autonomy. Honoring Fen's choice to continue treatment supports her autonomy and self-determination as outlined in the APS Code of Ethics. Negative consequences with competence. Continuing to treat Fen without the requisite specialized knowledge could breach the ethical standard related to competence, especially as a recent review on psychologist treatment of eating disorders has found that most measures of therapist competence had poor fidelity, meaning that the treatment was not delivered as intended. Burnout. Burnout has adverse outcomes on physician well-being, patient care, and the mental health care system, and can lead to decreased work productivity. Increasing training burden on physicians, along with administrative and therapeutic tasks, have been found in a review by Patel and colleagues to be one of the biggest contributors to burnout. Beneficence and non-maleficence. If, in my experience, leads to inadequate care, it could conflict with the principles of beneficence and non-maleficence, as eating disorders has one of the highest mortality rates of mental illnesses, and this could have serious considerations for malpractice. Professionalism. There is a risk that continuing treatment could be seen as a failure to recognize and act within the limits of one professional competence, potentially breaching ethical standards related to professionalism. With the APS Code of Ethics in mind, and after reviewing the case studies from Varkey, which grapples with conflict between similar principles of beneficence and autonomy, which highlights whether the patient is not making a reasoned decision due to temporary mental incapacity and the severity of their illness, I have come to the conclusion to refer Fen to a specialist. This choice aligns with the principles of beneficence and non-maleficence, ensuring Fen gets the best care for her needs. The negative impact on trust and autonomy, though considerable, is secondary to the ethical obligation to provide competent, safe care. Professionalism obliges psychologists to acknowledge their competence limits. While the therapeutic relationship does matter, it must not hinder access to specialized care outside my expertise. I plan to involve Fen in the referral process, support her during the transition, and clarify that this decision is in her best interest ethically. This approach balances my respect for Fen's autonomy and dignity with my ethical duty to offer competent care, solidifying the referral as an appropriate course of action. Thank you for listening.